Okay, so kind of part 2 of today then, for Tuesday, is looking at chapter 14, ventilator-associated pneumonia. That's what we'll be talking about. The first couple pages here are just the learning objectives. I'm not going to read through all those. Okay, so some of our key points here. So we have different definitions that we need to be aware of. So a VAP is a ventilator-associated pneumonia, which is defined as it develops 48 hours after the patient's been placed on the ventilator. Then a HAP is a hospital-acquired pneumonia. Okay, so occurs 48 hours or longer after admission to the hospital. It results from infection not incubating at the time of admission. Okay, and then an HCAP is a healthcare-associated pneumonia, and this generally affects patients that are residing in long care facilities or acute care. Okay, and this is something, these VAPs are definitely something that they keep careful track of, and they monitor them. That's why we do that PSB, bronchial brush specimen, PBS, or I forget, PBS I think, where we actually go in within the first shift, hopefully preferably the sooner the better, within the first few hours after a patient's been intubated, and we get that little protective brush specimen from the patient. So we're basically looking to see if the patient is already brewing a pneumonia. So if that turns up to be positive, or it has pathogens on there that are, related to pneumonia, they have probably come in with it. But if that specimen comes back negative and it's clean, and then a day or two down the road, or whatever, 3 or 4 days, whenever down the road they get a pneumonia, then they say that that's a ventilator-associated pneumonia. So that's why we kind of get a baseline from them once they're first intubated, to see if it's something that's brewing or something that happened as a result of being on the ventilator. Okay, so most of the VAPs are caused by bacterial infections. Can also be fungal, viral, also SARS. So early onset is considered 48 to 72 hours after being intubated. Okay, so remember the difference between these two things, the early and late onset. And then late onset would be then later than 24 hours. Keeping in mind that patients that develop late onset, so the ones that are greater than 72 hours, are more likely to be infected with multi-drug resistant pathogens. So MDRs, multi-drug resistant pathogens. Okay, so those are more likely to be in patients that have late onset pneumonia. VAP is considered the most common nosocomial infection, so something that you acquire in the hospital. Your risk is 3% per day during the first 5 days, and then 2% per day after 5 to up to 10 days, and then 1% afterwards. The incidence, this is some question that you're going to see, so highlight this. Your incidence is 8 to 28% for all intubated patients. Mortality rate is a big range, 5 to 48%. Depending on the infecting disease organism. And of course, if they have underlying disease and prior antimicrobial therapy. Prognosis, if we can treat them early onset, and we can find what antibiotic sensitive bacteria they have, If it is a late onset, then it's most likely multi-drug resistant, as I mentioned before. So we think about nosocomial infections. Just kind of think for a moment what other nosocomial infections that are pretty common in the hospital. So VAP being the most common in the ICU. Okay, but there's other ones that patients can get. I wrote down a few other ones. I'm sure they're from the textbook too. Is a UTI, so urinary tract infection from catheters, sepsis from their IVs and central lines, and surgical wound infections. Okay, so those are also nosocomial risks. All right, this is from chapter 14. Pill beans. This is where this lecture is based out of, so make sure you read through your textbook. So some of the more common ones is Pseudomonas, Klebsiella, so these are kind of broken down into gram-negative and gram-positive. So when we look at gram-negative, about 60% of all VAPs infections are with Pseudomonas aeruginosa, Klebsiella, and then E. coli, which is called E. coli, and then the Enterobacter. So those are the more common gram-negative. And then your gram-positive, the most common is methicillin-resistant Staph aureus, so your MRSA, which is predominantly gram-positive. So those are some of the names that you're going to want to remember. I'm trying to find my little highlighter here. Okay. All right. So make sure you're highlighting or taking notes. Again, following along in your textbook on chapter 14. All right, some of the different things that put patients at risk are all these listed. I'm not going to read through all of them. Host-related risk of having MRSA is also definitely a risk of having predisposing to VAPs. Okay, so all of these, along with host-related risk of having MRSA. So again, the pharmacologic, or if you're on steroid therapy, that's going to put you at more of a risk of getting a VAP. Also, inappropriate antimicrobial therapy. So if you're on an antibiotic that you really don't need. Overuse of sedatives and paralytics. So this is going to blunt patient's cough reflex and increase the risk of aspiration. Use of type 2 histamine antagonists and gastroprotective agents such as like Zantac or Pepcid. And then if you're already have a history of being multi-drug resistant organisms that you've had before in the past. So kind of looking back at those Zantac and Pepcid, so what happens there is that these change the acidity of the gut and it decreases it. So it changes the acidity of the gut, which decreases the incidence of gastric colonization by potential pathogenic organisms increasing. So it kind of gives the gut a place for them. By changing the acidity, it kind of gives them a place to kind of grow and colonize, where normally our acidic stomach would kill that bacteria. So it kind of creates an environment for them to thrive in. Other things that are going to put you at risk that are non-pharmacologic would be having an ET tube or a trach tube, just routine care of circuits, humidifiers, and nebs. So that's why we need to make sure that we're, not using humidifiers when we don't need them, or just taking care of infection control when we're changing out circuits, trying not to break the circuit, only changing out circuits when they're visibly soiled, taking proper care of the nebs, of the small volume neb cups or the aerogens, looking at other types of things such as reusable ventilator probes or sensors, bronchoscopes, endoscopes, anything that's going to be invasive or anything that we're adding on to the circuit that could transmit organisms. Okay, so we're kind of looking at the upper airway typically contain non-pathogenic bacteria, such as the group of Streptococcus, Haemophilus, and anaerobes. Okay, anaerobic gram-negative bacilli, most notably virulent forms of Pseudomonas and Enterobacter, are rarely found in the respiratory tract of healthy people because of our anatomic barriers. So we kind of, our upper airway, our glottis helps protect us from transmitting that upper airway stuff down to the lower airways. Like I think I have told you guys before, when Victor had sinus surgery that time, he was kind of brewing a sinus infection again the night before sinus surgery. He called them, the physician on call, and they just said, we'll put you on antibiotic in the morning, IV, but we're still going ahead because that's why he was having the surgery, because he kept getting these recurrent sinus infections. I would bet money that when they intubated him for the procedure, whether it was actually ET tube or an LMA or whatever they used, I think whatever was in this posterior oropharynx probably got introduced to his lower airway, because then he developed pneumonia shortly after surgery. So the pathogenesis of VAPs most often involves colonization of aerodigestive tract with pathogenic bacteria, aspiration of contaminated secretions into the lower airways, which I believe happened there, colonization of the normally sterile lower airways and lung parenchyma with infectious microorganisms. So patients that have an ET tube and are on a vent, there's a dramatic shift in the flora of the oropharyngeal tract to gram-negative bacilli and Staph aureus. So aspiration of these contaminated oropharyngeal secretions, and in some cases gastroesophageal contents, happen because the patient's not able to protect their airway. So that's why we need to make sure that we're doing proper oral care on these patients, also making sure obviously that their cuff is properly inflated but not overly inflated, keeping their head of bed up. These are all part of the different protocols that we do to make sure that they're not aspirating. So there's kind of a lack of a precise definition for the diagnosis of a VAP. This can result in a failure to accurately diagnose it and then lead to inappropriate antibiotic therapy. Okay, so that's why we kind of make sure that we're doing those protective brush specimens so that we can treat the patient, be on the lookout of it, track it. It has to do with like Medicare reimbursement and all that stuff too. So just some of the different terminology basically. So the CDC surveillance definition uses the term ventilator-associated event, which describes a range of conditions and complications that occur in a patient on a event, including a VAP. Okay, so a VAP is kind of under the category of a ventilator-associated event. So they need to make sure that they diagnose it properly by using objective data, figuring out when the time of this all happened, so clearly defined time criteria, and the exclusion of X-ray. If you look at page 283, it kind of helps differentiate how they define this. So this again is kind of looking at some of the CDC surveillance, what they're kind of looking at on what could be the different causes of the VAPs. And then here was that other clinical criteria that they use to kind of help score it, basically. And you'll have a little assignment that's related to these different scores. So in this one, they're taking into consideration the patient's temperature, the white count, whether or not they have secretions, what their PF ratio is, a chest x-ray, and what type of growth they might be having from sputum. And this is actually from Chest Magazine, or not Chest Magazine, but Chest Journal. Other things that they use to to diagnose it is they're looking at doing a bronchoscopy. They could be doing a VAL, doing a lavage, a little mini lavage, that protective specimen brush, that's the PSB that we have to do. I think I always say PBS, but it's PSB. Or blinded bronchial sampling. The different ways of where they can actually obtain cultures from the lower respiratory tract. Then they look at this microscopic analysis of the cultures using appropriate stain to see if they're gram-positive or gram-negative. So these samples can help us determine whether or not there is a bacteria in the lower respiratory tract. So treating the VAPs, making sure we're on the proper therapy, initiating empiric antibiotic therapy as long as the patient doesn't have risk factors for multi-drug resistant pathogens. On page 286, table 14.3 lists certain pathogens with the recommended type of antibiotics they should be treated with. So if you look at page 286, it can kind of tell you what are some of the different types of, whether it's like cephalosporins, levaquin, or vancomycin being a heavy-duty one that's usually used for MRSA. So different types of antibiotics depending on what type of pathogen that they're growing. So different strategies that we use. Vent bundles are huge. That's something that they put into place that includes like proper oral care, keeping a head of bed up. Often you suction a patient, whether or not they're on antacid. Also making sure hand washing obviously is huge. I'm sure at most facilities you've seen that they sometimes have those little hand washing spies out there to make sure that you are washing your hands. I know that at Lutheran they have like sensors that are on their badges that they have to kind of tap to show that they've been using the alcohol wipes. Just keeping in mind some different pathogens, especially C. diff, which I know is not a VAP, but C. diff is one of the ones that you actually have to wash your hands with soap and water. Maybe COVID-19 is too. Some things that we can do, I mean, if we can avoid intubation, that would be great. Making sure your patient is in a semi-recumbent position. Again, only changing the circuits when they're grossly contaminated. Using an HME when possible versus a heated circuit. Avoiding aspiration of the subclottic secretions. Kinetic beds, kind of keeping them moving. Those rotating beds. Appropriate disinfection and sterilization techniques used on all your different equipment. So different pictures of things for prevention. Oops. Sorry, my slides in advance. Right, there we go. All right. Non-pharmacologic, identifying a dedicated person or group for monitoring VAP rates, which they do have established. Using closed suction catheters and sterile suction technique, trying to make sure they don't have a large amount of volume, gastric volume in their belly, so that reduces the risk of aspiration, regurging. Extubating, removing NG tubes as clinically indicated. Trying to avoid contamination with vent circuit condensation. So internal feedings may predispose a patient to a VAP. So again, what that does is it elevates the gastric pH, which then can lead to gastric colonization with pathogenic bacteria and cause gastric distension. So like tube feedings is what they're talking about. So this can lead to an increased risk of reflux and aspiration. So instead of doing continuous feedings, it's advised to do intermittent feedings, and again keeping that head of bed up at least 30 degrees. Making sure that we're not sharing equipment, being careful when we're using our inline nebs, considering the use of expiratory line gas trap or filters, and using oral intubation rather than nasal. We don't see too many nasal tubes anymore, but occasionally you do. Alright, so this is a picture of the CAS, continuous aspiration of subglottic secretions. I know that a lot of facilities use these type of ET tubes. I've seen a couple of in-services on them when I was at Good Sam's. Seems like a pretty slick idea, so you just kind of have a suction set up to one of those ports there that just kind of continuously gets the secretions at low suction. Unfortunately, they're expensive, but it's one of those things that you have to kind of figure out if the benefits outweigh the costs. So what happens is the secretions pool around that ET tube cuff, and then they act as a reservoir for disease-causing bacteria. The CAS have a dorsal lumen above the cuff that allows for continuous or intermittent, so it just depends on how you want to set it, suction of those tracheal secretions. So you probably have to be kind of aware if it's continuous, making sure that it's low enough that's not doing any damage to the mucosa, the airway. One study actually showed that using a CAS can actually decrease incidence of a VAP by 50%. But like I said, they are expensive. Another thing, administering stress ulcer prophylaxis, considering possible prophylaxis, intestinal decontamination. Again, you have to be careful of multi-drug resistant patients. So we want to try to prevent this. Actually, we want to prevent administering stress because we don't want to change that pH of the gut. Okay. We also want to avoid central nervous system depressants because we do not want to inhibit or suppress their cough. So these are things that we should try to prevent. Again, we want to make sure that our patient has good nutritional status to help their immune system, avoiding agents that impair their pulmonary defenses, such as aminophylline, anesthetics, certain antibiotics, steroids, again, sedative narcotics, minimize the use of invasive procedures, remove or treat disease states that affect the host's defenses when possible, so trying to correct or treat these things, these underlying things, if able. So if they have an acidosis, make sure we're keeping them hydrated, make sure they have enough oxygen, watching for acid aspiration, stress, treating DKA, liver, kidney, and heart failure. So all these actually decrease their immunity.